aplastic anemia. Two things he told me: for the last 20-25 years, two diseases, nothing has changed. One is aplastic anemia and the other one is acute myeloid leukemia. Maybe 3-4 years back I'm talking. Now there are few improvements that have come, but rather than discussing all the Western data, if I go to our own Indian data, more than considering about the improvements, the real world data is only 30 to, I can't say 30 itself is pushing more. Only 30% of patients who really need a treatment, I think they are getting some kind of treatment. And a lot of data says that the 5-year survival rate, according to the SEER database, is around 20-30%, but that is too much of enthusiasm in India, I suppose. If I see 10 patients today, after 5 years, even seeing one patient alive of AML is a big bonus to me. That's the real world data in India. But when it comes to FLT3, now more and more genetics, more and more next generation sequencing and everything is coming up. We have started learning about the biology of the disease in detail, where AML, once like say lymphomas, where you have gone into the biology much deeper. Nowadays we have started knowing a lot about AMLs also. Actually speaking, AMLs is just a continuum of, I can say, an MDS/MPN kind of a category, where there are innumerable number of mutations that do play a role. And people have seen that it is not that a patient, say for a diagnosis or got some particular mutation, he gets treated and the disease relapses back. Many times we have seen that there may be some clones, different clones are there. It is kind of a polyclonal disease, I should say. Some clones with some mutations, which after a very good treatment, after good remission, achieving CR1 and consolidating the patient, when it again comes back, it comes back with a different phase. So it is not very surprising to see that at diagnosis some mutations were absent, and after when the patient relapses some mutations may be present. When I come to this particular topic of the day, that is FLT3, FMS like tyrosine kinase 3, why I am here is because it was my say the dissertation topic during my DM days. In our own institute in Calcutta, we did a study on say 187 patients who got enrolled into in a period of 3 years in that institute, of which I should say this FLT3 mutation percentages were somewhere between 22 to 24, of which FLT3 ITD, which is the internal tandem duplication, was kind of high, and maybe 1/4 of cases, and 1/5 was the TKD mutations. Worldwide data also is kind of similar to what I have said here. Around 1/3 of patients at any point, they may have something to do with the FLT3 gene. Why it is important? Because it indicates a subgroup of patients who are really, say, kind of on a bad prognostic note, young age of presentation, very high CR1, I mean the refractoriness to the induction chemotherapy. More than refractoriness to the induction chemotherapy, these patients are notoriously known for getting it back. There is high degree of relapses. So tomorrow, whenever I see this FLT3 mutation positivity in a patient, the first thing I do to my patients is, if they are transplant eligible right from day one, whether they are doing it or not, whatever happens to them, with a word of caution, I always say the prognosis may be bad. And one more thing is, try to get on to a bone marrow transplant from any kind of a donor. It may be an alternative donor also. What is the FLT3? Just routine, whatever happens in hematology has got something to do with tyrosine kinases. This is again a tyrosine kinase inhibitor. So I mean tyrosine kinase domain. There are two types of mutations, as I said. Internal tandem duplication. There is something adding up here. So this is not working. Something adding up here is the most important thing which happens, which is the most, say the bad one, which is called as FLT3 ITD, or internal tandem duplication. So if you really ask me, these are all things I have discussed already. Some growth providing mutations, say 5-10 years back, before the ratified trial started, I should say that till on date in India, somebody with FLT3, my first line of answer will be get on something like a total therapy, which Dr. Pankaj used to do in Chandigarh. Get on with a flag IDA or something, or even a 7+3. I mean, transplant them in CR1 itself, provided you have got the resources, provided the patient has got the resources. But whether it is feasible everywhere, I don't know, but that is what we have to say to the patient, at least to be on the safe on the legal side. Yes, transplant if feasible. Otherwise, because after spending whole much of money on consolidation, 3-4 cycles, and later within a year, the patient coming back with the disease in a poor state, that looks very bad. So yes, time and again, the studies have proved that transplant is something which needs to be done in FLT3. But when I come to, when I was studying more into the details of FLT3, one thing which we are not doing, but slowly some labs have started doing in our country is, many times when we send a combo quest or what are the oncomine panels for AML or MDS, etc., we get FLT3 positive or negative, ITD or TKD positive or negative. Going a step behind, beyond, Though none of the Indian labs have got a standardization of it, ideal thing to do is to look at the allelic ratios. That is, comparing the wild type to the mutant type, allelic ratios of FLT3, where there are a lot of controversial data saying that less than 0.5 is considered to be a low allelic burden. Some studies, this 0.75 is low allelic burden. I don't know whether it makes any sense for us right now, because most of the times we ask these patients to undergo a transplant, whether looking at allelic ratio will have some impact on our future thing. But ELN has taken this into account, because if you see here, NPM mutations positivity with a wild type FLT3. Yeah. Oh, that's fine. So if you see here, this NPM mutated levels with FLT3 wild type is the one which has got the best prognosis out of your patients. And next comes, we know only FLT3 positive or negative, but these people are trying to divide the data into FLT3 low allelic ratio with FLT3 high allelic ratio, where the low allelic ratio people tend to have a relatively better prognosis compared to the FLT3 high allelic ratio. At this point in time in India, can I do it? I don't think our labs are standardized to do this, but just something this is new that's coming up. So based on this, the year in 2017, they have even put this FLT3 ITD low allelic ratio into the favorable risk group of the prognostication markers. So basically, FLT3 high comes into the intermediate, FLT3 high and other things goes into the bad prognostic groups, whereas NPM positivity with FLT3 low gets into the favorable risk group. But how far this is kind of reproducible in our setting, I really don't know, but this is what it is. So that's about the biology of FLT3. Coming on to the different drugs that are available. One very easy alternative option, or a less cost option we all are using nowadays for FLT3 is, we really don't know whether it is working or not, but this is sorafenib, which I have used in multiple patients in spite of whole lot of this hand-foot syndrome and sometimes severe cytopenias and other things. Somewhere here and there, on and off, depending upon how the patient is, we do use it, even in post-transplant settings also. But something that has got approval last year was this midostaurin, which was the result of a very long-running trial, namely the RATIFY trial. There are multiple trials into this. These are the three important phase 3 trial among this is the RATIFY trial and the CALGB1, which compared midostaurin plus chemotherapy, that is induction chemotherapy, 7+3 in consolidation, opposite to my chemotherapy alone with some placebos. So I will be discussing something about this trial data. This was a trial study. One thing here, they took patients only up to 60. So there's another CALGB trial which is ongoing. The results are yet to be out, where they have included patients up to 70 also, where they are giving along the routine 7+3, and from day 8 to day 21 for around say 2 weeks or something, they are adding up this midostaurin, which is an oral tablet. Why day 8? I really don't know. They don't want to increase the toxicity by combining with chemotherapy. But one thing is, to even get a result of FLT3, it may take at least, my lab, it takes around 4 to 5 days. Maybe that was the reason why they started day 8. But there may be lot of labs or lot of centers where even getting within 7 days or 8 days may be tough in our country. But the issue is, after chemotherapy, you can always start it as a kind of a oral treatment. So this goes on even into the consolidation phase. And these patients, after consolidation, suppose the patient is not going for a transplant, they even given a maintenance up to say 12 months or something. Why 12 months? I don't know. There is no rationale behind this study, but in the sense, why 12 months? But I think most of the relapses, if at all they have to happen, they happen in the first year. So maybe that's the reason why these people have taken 12 months for the maintenance. But I will go much more deeper into the data to understand what is what. This is in general what happened to the patients whomsoever was put on midostaurin compared to placebo. It is not, subgroup analysis was not done for patients who underwent a transplant. If this study, you see, this is the blue one is the midostaurin arm, and this is the placebo arm. At the hazard risk ratio for death, I should say, is around 0.78 in the midostaurin arm, which means that overall, if the patient goes into anything, whether in between he goes into a transplant and stops midostaurin, or he continues midostaurin without any transplant up to 1 year, they have proven that there is a decrease in death rate by around 22%. And when it comes to patients who have been censored at the time of transplant, this actually speaking, post-transplant midostaurin is not approved for the post-transplant maintenance. This is only till transplants they were given midostaurin. And here also, if you see somewhere around say with a HR ratio of 0.76, around 24% deaths were prevented in the midostaurin arm. Unfortunately, when I went back to the trial, this trial is not powered enough for subgroup analysis and all, but this is the pattern or the trend that is being happening. Unless we do use it, we may not be knowing what is the real world data is all about. So putting together and transplant when it should be done, if you see here very clearly, when the transplant is done in the first CR, I mean CR1, when the patient achieves remission, some kind of remission, it's always better to transplant even or in spite of even taking midostaurin. If even transplant is done out of CR1, using midostaurin or not was not making a much difference to the patient's outcome. So, I mean, putting together all this, I will feel that suppose if it is feasible in a very, say, theoretical setup, start a midostaurin along with induction chemotherapy. So whenever they achieve CR1, I think get on with the transplant, and then unfortunately post-transplant there is no maintenance. And this also proves that yes, this will have some effect or the differences in the overall survival of the patients. So what happens to patients who didn't underwent any transplant? Here also they have they have proved that by giving it up to an year, with a HR ratio of, I mean, higher hazard risk ratio of around 0.47, around a good number of patients were still holding good compared to the non-midostaurin arm. So can I say right now that these drugs are working? Main always, whenever you draw a trial, when you compare nothing versus something, always something is better. So maybe this is what the results are all about. But the something, how costly is the something is all about. Something is going to be, I don't know exactly how this is going to be costing, but around a 1.5 lakh cycle is what this company is trying to come up with, I suppose. So you are adding up another 6 lakhs to the patient's cost. So is it validated at this point? I really don't know. But if the patient, when you are looking at the bigger scheme of things, if you have started like, if you are prepared like to do a CR1 transplant, I think even giving one cycle of midostaurin, this is what I may prefer. Always we should have our own data to say that what is working or not. But always I feel something. Already 7+3 is very toxic. The drugs are cheaper, but the supportive care and the cytopenia, everything is the one which really throws me out. Is midostaurin, adding midostaurin, it puts me back thinking that is it going to be something which is going to make the cytopenia more worse. But according to the trial data, apart from anemias, I don't think other cytopenias are not very worse. And sorafenib, I had very bad experiences with all the hand-foot syndrome and all, which again, if you see here, the midostaurin arm, this rash plus desquamation, compared to the placebo arm, it is on a higher side. I don't know practically, unless we use it, I really don't know whether it is manageable or not. So this is what it is. I mean, initial conclusions to say, at this point in India, we don't have labs which are skewed enough to give a proper allelic ratio of FLT3. My way of looking at it is, if FLT3 is positive, get on with induction chemotherapy plus or minus midostaurin. If we can do a CR1 transplant, I think that will be the idealistic situation. If not, we may, depending upon how much the patient can continue. But as I said, this drug is approved only for the induction chemotherapy alone. We don't have anything right now for, say, the relapse setting or the post-maintenance, post-transplant maintenance. There come the other two drugs. The one drug which already got its approval this year is guzatinib, which again is some...
You can just wind because we have slides, many of them.
Okay, fine. Sorry. So this is like, again, a very, this just got approval this year, where FDA has approved it for the relapse refractory conditions, where if you see the, I mean, median overall survival in the guzatinib arm was around 6.2 against 4.7 in the salvage chemotherapy arm. There is some improvement that's happening, but guzatinib again is like imatinib, I should say. There are some mutations in the TKD or the ITD domain which may cause resistance to it. So that resulted in the generation of this new drug which got approval just 2 weeks back, the gilteritinib, I suppose. This already trials are happening to use it in the relapse refractory settings or even post-maintenance, post-transplant maintenance. But whatever said and done, FLT3 till on date, I feel if somebody gets FLT3, I'm not so happy. They don't do very well, to be more frank. Just a fast outlook of the guidelines. Both NCCN as well as ELN, they are mentioning the name of midostaurin in the patients who are FLT3 mutated. NCCN alone there is a footnote saying that midostaurin maintenance is of some reported benefit according to the ratified trial, but ELN is not mentioning that because of lack of evidence. These are all some of the abstracts which are there in the ASH 2018. Just everything is Greek and Latin. Just remember the 3 drugs available: midostaurin, gilteritinib, and guzatinib, where midostaurin is already in January is going to be available for our use.
Okay, thank you.
Thank you.
I wanted Dr. Jose to, how practically is this, how do you look into the drug and how practical do you think?
Excellent talk, Dr. Kishore. Very nicely summarized and very concise. So the way, I don't know what your observation is. See, when the host is weak, then this multi-resistance take over. That's an observation I've found, you know. FLT3 or DNM T3 mutation or P53 mutation, these are the patients who get multi-resistant bugs for some reason. So maybe in the Indian context, adding an anti-FLT3, maybe we don't know whether they're going to be protected from these bugs. So we will have to use these drugs and see whether the outcomes are better, you know.
Western data, hardly they talk about all this GNB sepsis what we have got. Even in my study, there was a 35% induction death in a government setup. So all those things does matter even before midazolam starts working.
What was the TRM in addition of by adding a midazolam? What was the TRM rate?
TRM rate or not much
Increased or
different.
decreased?
It is not, I mean, you mean the during treatment?
Induction phase.
Induction phase. Induction phase, there was no big difference.
No
That's
big
what the trial says. In the long term, if you see...
On your real practice?
I haven't used midazolam.
Not available.
Indeed, we wanted for one patient for systemic mastocytosis. Unfortunately, we are not able to
Yeah,
import
Dr.
it.
Jayachandran in the institute. Dr. Jayachandran, in the institute, how do you approach a case?
For FLT3 AML, actually, our approach is